Good morning, everyone. My name is Belinda Pinto. I'm a research scientist in Eric Wang's lab, and today I'll be talking to you about hypersomnolence or hypersomnia in myotonic dystrophy, which is seen in both DM1 and DM2. So the goal of my talk today is to give you a brief overview of the studies that have been done in the last few decades that shed some light on what could be causing hypersomnia in DM. And ultimately, hopefully, this will give us alternative questions that we can answer and develop new methods of treatment or alternative methods of treatment. So 80% of DM patients, and this is DM1 and DM2, have hypersomnia. And they say that it has a profound impact on the quality of their life. Now, hypersomnia literally translated means excessive sleepiness, and it's seen in many disorders. But DM hypersomnia has very characteristic features that are reminiscent of idiopathic hypersomnia. So DM patients have excessive daytime sleepiness, or EDS, but without cataplexy. So it makes it different from narcolepsy type 1. They have less than one sudden onset REM episodes or SOREMs, where if they're taking a nap or they're going to sleep, they immediately enter into REM. They tend to have prolonged but unrefreshing nocturnal sleep, so they can sleep greater than 10 hours, as Eric mentioned before, but it's not refreshing. So they wake up very tired. They have severe sleep inertia, which means it's difficult for them to wake up. And when they do, they have sleep drunkenness and reduced alertness while awake. And so they have this increased need to nap, but again, the naps are not refreshing. And so currently, the best method of treatment is giving them modafinil, but it doesn't work in really extreme cases. And so we need to find other methods to treat this symptom. And for that, we need to understand more about what causes hypersomnia in DM. And for that, we look to the two-process model of sleep regulation. So this consists of a two-process model where we have process S, or the sleep homeostasis process, and process C, and the circadian process. And it's a balance and interplay between these processes that determine when you go to sleep and how well you sleep. And so in the case of process S, the sleep homeostasis process refers to the buildup of sleep pressure while you're awake, which then dissipates while you're sleeping. And the circadian process refers to the 24-hour circadian rhythms of wake and sleep that take place every day. And there's evidence that suggests that both of these processes are affected to some degree in DM. And all of this data has been obtained in the context of DM1. We don't have any data on DM2 as yet, and we should really get more of that. And so first, I'm going to tell you what evidence there is that process C is disrupted in DM. And then for the last couple of minutes of my talk, I'll talk about process S. So one of the first pieces of evidence that suggested that circadian rhythms are affected in DM was studies done decades ago in the 1970s that showed that there were abnormal rhythms or weak rhythms of a circadian rhythm production of various hormones. And so these rhythms are weaker, they have a reduced amplitude. And then nothing was done for quite a few years till Valeria Sansone's group published a study in 2021 where they analyzed circadian rest activity rhythms in DM patients with excessive daytime sleepiness. And they did this with actigraphy and sleep diaries. And here too, they found that these rhythms had a lower amplitude or they were weaker. In addition, what they found was that there was a delayed phase where DM patients tend to sleep in the later portion of the night, as indicated by the blue bar shown over here, compared to unaffected individuals. Now, this study was done over the course of 1 week, but there was another group that studied one DM patient where they did this kind of analysis in this patient over the course of 3 months. And so they used sleep diaries and actigraphy again. And what they found is when you look at the overall rhythms, you have these periods where the patient has a 24-hour rhythm of sleep and wake, and then sometimes where they have a 25-hour rhythm. So the period changes. And so this suggests that this individual has a non-24-hour sleep-wake disorder, which is a recognized circadian rhythm disorder. And now it's not really known what causes this disorder. These patients, generally non-24-hour sleep-wake disorder patients, have excessive daytime sleepiness. And it's thought that maybe they can't really entrain to our world with 24-hour rhythms by light cues. And so the way they treat this is by giving them powerful time cues in the form of either light therapy early in the morning or melatonin agonist treatment at the night every day at the same time. And so this approach was used for this particular DM1 patient, where she was given a melatonin agonist to be taken every day at bedtime. And it was found to improve her sleep-wake rhythms and her excessive daytime sleepiness. So it'd be nice to do a bigger study on something like this as well. And so it looks like circadian rhythms are disrupted in DM, and it contributes to hypersomnia in DM. So the circadian clock is what helps to regulate these rhythms. And so we want to see how the DM mutation affects the actual circadian clock. And we're doing this by performing studies in mouse models of the disease as well as DM cell culture models. And with respect to the mouse model, we began our analyses with the DMPK480 knock-in, which you've heard about quite a bit in the last couple of days. And so this mouse was generated or made in the Swanson lab, where they knocked in 480 CDG repeats in the 3' UTR of the mouse DMPK. Now, this model does not show any muscle phenotypes, but when they examined the CNS regions, they found that there were prominent nuclear RNA foci by fish in the choroid plexus tissues. Now, the choroid plexus is a secretory tissue that's present in the ventricles, the lateral, third, and fourth ventricles of the brain. And when you do fish, and the signal over here is shown in green, you get very prominent foci in the lateral and third ventricle choroid plexus and smaller foci in the fourth. So all of our tissues are affected. So to look at whether there's actually circadian rhythm defects in these mice, we collaborated with Karen Esser's group at the University of Florida. And for these studies, what you do is you house mice in individual cages like this, and each cage is fitted with an infrared sensor. And then you put these cages in a light-controlled environment like this one. And then the activity data comes out in the form of actograms shown over here. So this is the activity data for one mouse. So at the beginning of these studies, the mice are entrained to a 12-hour light-dark cycle. And since mice are nocturnal, they're inactive in the morning and more active in the night. And then if you want to look at their innate circadian activity rhythms, you have to move them into a period of complete darkness where there are no time cues at all. And what is that even in this environment, they are inactive in the subjective day and active in the subjective night. And in addition, what is that the time of onset of activity is the same from one day to the next, as indicated by the dashed line going down straight. And so this indicates that this particular mouse has a 24-hour period. So if this dashed line starts slanting to the left, that means the period's getting shorter. And if it starts slanting to the right, that means the period's getting longer. And so we did these analyses with wild-type and knock-in mice. And what we found was that when you look at a knock-in mouse in the period of complete darkness, that line starts shifting a bit to the left every day, indicating that this mouse has a shorter period. So we quantitated this data in wild-type, knock-in heterozygous, and knock-in homozygous mice, and you can see that there is a significant shortening of the circadian period in these mice. Now, there's many tissue clocks that help to regulate circadian activity rhythms, and the most prominent one is actually the choroid plexus, which I mentioned is affected in these mice. And so the next thing we wanted to do was to examine if the molecular oscillations of the core clock are disrupted in these tissues. And so we do that by examining the oscillation of a circadian gene that's been fused to luciferase, and we can basically culture these choroid plexus tissues you can keep them in culture for weeks or months even, and we can get the tissues from all the different ventricles, keep them alive for many weeks, and then by examining the oscillations of the reporter, we can look at how the clock functions in these tissues. So we get very nice, strong oscillations in these tissues. We don't have data in the knock-in explants just as yet, but in place of that, what we have been able to do is to look at the effect of the expanded CDG repeats on these oscillations in human cells. And so these cells are generated in our lab, which carry the reporter as well as CDG0 or CDG480. And by bioluminescence imaging, we can get nice, strong oscillations, as you can see here. And when you calculate the period of those oscillations, we see that there's a significant shortening, again, of the circadian period of the oscillations. So it looks like expanded CDG repeats do have an effect on the core clock itself, and this could be responsible for the activity rhythm defects that we see in the mice. And so we're continuing these studies right now, where we're looking at how the clock is affected in DM1 and DM2 patient myoblasts. We're doing this by, again, imaging the reporter, but also doing transcriptomic analysis. And we want to extend that further to actual behavioral rhythms in patients. Is DM hypersomnia really a result of a non-24-hour sleep-wake disorder? And so we're collaborating with Dr. Subramoni and Dr. Sansone to look at not just the activity rhythms by actigraphy, but we're also going to analyze the rhythms of melatonin production in these patients in their urine. And so I've told you now, it looks like circadian rhythms are disrupted in DM, and this is what's contributing or partly contributing to the hypersomnia we see. And for the last few minutes of my talk, I want to show you how there's evidence that even process S, or the sleep homeostasis process, might be affected in DM. And so from studies that have been done, again, since the 1960s and 70s on patient postmortem brains, as well as with patient samples and now the mouse models we have, it looks like both the arousal promoting and the sleep promoting processes are affected in the DM1 brain. So with regards to arousal, it looks like arousal is also called wakefulness. It looks like arousal is weaker in DM. And so there's many different arousal promoting centers in the brain, as I've shown here, of which prominently it looks like in patient postmortem brains, the thalamus and the brainstem are affected. So in these studies, what they found was that there's a loss of serotonergic wake-promoting neurons in the dorsal and the median raphe in the brainstem. But they also find these abnormal cytoplasmic inclusions that are present in pretty much all of the thalamic neurons, but prominently in the anterior thalamic neurons that help to promote wakefulness. It's still not known what causes these defects and how they affect the arousal process. In addition, it looks like there might be weak orexin signaling, which is an important wake promoting pathway in DM or in general. And so, if you look at the brain, orexin is produced by the hypothalamus, shown in yellow over here, and is released to different regions of the brain to help promote wakefulness. And studies have been done in a DM patient, CSF, or patients that have EDS. And in some of these patients, you do see a lower amount of orexin. In addition, a recent trial was done by Harmony Biosciences with pitolisant, which targets this pathway, and they find that it does help to improve wakefulness in DM1 patients. And so potentially, the orexin signaling pathway is affected in DM1. Now, things are not okay on the sleep side of things either. There are defects in sleep promoting centers. Again, here the thalamus comes into play. So the thalamus helps to promote wakefulness, but it also helps to regulate rhythms in sleep. And again, we know that there are these inclusions that are present in these the thalamic neurons, but we don't know what they do. But they could contribute to the abnormal sleep structure that you see in DM patients. And finally, as Eric has mentioned, there could increased GABA signaling that we see. So GABA is an important sleep promoting pathway. It's produced in multiple regions of the brain, shown by these blue spots over here, released through different regions to help promote sleep. And DM patients are thought to have an increased GABAergic tone because they have an increased sensitivity to GABA agonists. And from studies that have been done in mouse models, we know that there seems to be increased extracellular GABA that could be contributing to this, as well as missplicing of some of the subunits of the GABA receptors. And so what it looks like is that there's multiple places where arousal and sleep are affected in DM, and this could be contributing to DM hypersomnia, but we still don't know how this is. What is it because of expanded CTG repeats, loss of muscle blind, RAN translation, other mechanisms? We have absolutely no idea. So we have a lot of ground to cover to address how these issues are affecting sleep promotion in DM. And so finally, I'd want to summarize by saying that what I've shown you today is that we propose that there are perturbations to both process C and process S that contribute to DM hypersomnia, where the hypersomnia is the result of a weak arousal drive, as well as low sleep quality and altered sleep structure. And with that, I'd like to acknowledge the Wang Lab, particularly Eric, and our collaborators who really helped us set up these systems in our lab. I'd like to thank the Center for Neurogenetics at the University of Florida. It's a great group to work with. And last but not the least, I'd like to thank my funding source, MDF and DMCRN. And we have a few posters from our lab at the conference, so please stop by them today if you didn't get to see them yesterday. I have a poster too if you want to talk to me further. Yeah, with that, I'll thank you for your attention and take any questions.
So how have we looked at the clock genes? What happened to the clock genes because of the CTG repeats? So do you think the clock genes, for example, per one period, actually, it's getting reduced or getting methylated? If it's getting methylated, you see the sleep people, other circadian people, they think, okay, they have tendency to sleep more, these kind of mice.
What I didn't present today is we've done a lot of work in fly models of the disease. Yes, we've looked at fly models of the disease where what we see is there's a delayed degradation of the PER proteins. So in the Drosophila model, that's what we see, delayed degradation of PER, no effect on the other clock proteins. And we're trying to figure out what it is. We think that it's not a splicing issue, but we have evidence that potentially the expression of the repeats may cause lower gene expression in other genes that are related to the clock, but not the core clock genes themselves.
Great talk. Thank you. And I was wondering with the mice, thinking if you continue to say monitor those mice, would you almost continue to see a shortening in that circadian rhythm from that 24-hour period we were like?
Yes.
And would that correlate almost to a lifetime of patients having these sleep disturbances and a continued shortening as time goes on?
A couple of things. So what we think, for example, in that one patient where they looked at, they saw a change in rhythm. So yes, if we follow those mice for a very long time, it occurs that we might see a shifting as well. The other thing to keep in mind is typically people will entrain to your light cues. Sunrise helps us to reset every day. It's possible that DM patients are not able to actually entrain that way because we know that, for example, loss of muscle blind does affect neurons, and the entrainment pathway does require communication between the eye and the suprachiasmatic nucleus. So it's possible that's something that's affected. We want to look at this more in the mouse models for sure. And the other thing to keep in mind is in that one patient that it was a 24 and 25-hour period, but in the mice we're seeing a shorter period. But that actually depends on your endogenous clock. So even with unaffected people, some of us have longer periods and some of us have shorter periods. So when you don't have regulation of that, which way you go would just depend on what your innate clock is like. And so we might see variability between DM patients based on what their innate clock is probably like, and maybe in the mice models too. Yeah. All right.
Great. Thank you very much. So next we shift gear a little bit and we hear from Dr. Perez about new insights in DM2 and the effects of exercise.
So good morning. It is my pleasure to present today the study that we are doing. We started this year, funded by Myotonic Dystrophy Foundation, and it is also registered in clinicaltrials.gov. We are investigating the benefits of a physical therapist-guided exercise program in patients with myotonic dystrophy type 2. So there is not much in the literature about exercise in myotonic dystrophy type 2. We found this paper by Conto and colleagues in 2020, Muscle and Nerve, and we were encouraged by the results, although it is a small study, only 10 patients were included. But they showed that a 16-week combined resistance and aerobic supervised exercise training with a frequency of twice a week and performed at hospital settings with complex equipment was safe, improved the functional capacity of the patients, decreased the blood pressure, and was associated with an increase in the lean body mass and bone mineral density using the exercise scan. So they use as a comparator an internal 12-week control period before the exercise intervention. So we were encouraged by these results, and we wanted to explore the role of exercise in this muscular dystrophy, for which we don't have treatment. So we wanted to know if we could get same benefit if maybe the exercise was not supervised, so supervised versus no supervised. Also, if maybe the exercise is also beneficial at home when the patient performs the exercise at home and the patient doesn't have to come to a clinic or to the hospital to do the exercise. And also, if we can use another tool that we use in other studies that we have, like electrical impedance myography, and try to avoid things like DEXA scan that use radiation. So we come up with a study that has a crossover design, and I'll show you that in a few slides. So our first aim is to determine the effect of this physical therapist-guided exercise program using a 2-period, 2-sequence crossover study in these patients. So basically, we hypothesize that exercise is beneficial in those patients who are supervised when they do it by a physical therapist, either virtually or in person, and also in those patients who do the exercise on their own without supervision, but after a period of training by a physical therapist. And then we also want to assess the electrical pattern using this electrical impedance myography device that I will show you in a sec, if this electrical pattern is also improved in these settings. So this is the device that we use for electrical impedance myography from Myolex. It's a small device. I think many of you may be familiar with this technology. You basically put this small device on the muscle that you want to test, and there are 4 sensors. And this is painless, it's a very weak current, and the 2 outer sensors are the ones that apply a weak current, and the inner sensors are the ones that measure the voltages. And then we get some parameters from each muscle that you can see on your left: resistance, reactance, phase angle, and a frequency center. For example, the resistance correlates with the fat infiltration of the muscle, also with the subcutaneous fat that the patient may have over that muscle. If we don't do any intervention, so as the muscle disease progresses, you will expect a higher resistance. And this is here on your right. This is from another study. It's a patient who the resistance for the rectus femoris muscle and the deltoid muscle at visit 1, you can see that it's lower than visit 2 occur almost 1 year later from visit 1. So without any intervention, we expect the resistance to go up. And so this is what we want to see if the exercise has any impact on these values. So this is the study design. The study has a duration of 6 months. The first period is 3 months. The second period is other 3 months. In the middle, you have the crossover. We have 3 groups. We are targeting to recruit 24 patients, 8 patients in Group A, Group B, and Group C. So Group A will be doing some of these exercise sessions in person during the first period of the trial, and then they will go on their own on the second period. Group B, they are doing the exercise virtually under the supervision of a physical therapist, and then during the second period, they go on their own. And Group C, they go on their own from the beginning. The physical therapist at the screening visit teach them the exercises, and then they go on their own 2 sessions a week. And then during the second period, they will continue doing exercises under supervision virtually. So this is basically a table summarizing the assessments that we do at the screening at 3 months before the crossover and at the end of the study. You can see that independently where the patient is randomized to, and we use an NIH randomization tool for that, but independently of that, the patient has to come to clinic at least 3 times for the screening at 3 months, and then at completion of the study. We do all this assessment with focus on assessing fatigue, daytime sleepiness, and pain. And during the first period, the patients, during the whole study, the patients have exercise diary that help us to monitor the compliance of the patient, especially those patients who are doing the exercise on their own, to make sure that we monitor the compliance. And actually, there are some phone calls that we do for that purpose. And also, the physical therapist will assess if the number of sets and the number of repetitions can be increased. So these are the inclusion criteria and exclusion criteria. So we're including patients with myotonic dystrophy type 2 and genetic testing between 18 and 80-year-old. It was 17-year-old, but we just changed or modified the IRB a little bit to include more patients to 80-year-old. They have to be ambulatory without the need of any assistance of device. The EKG has to be normal, and we can do an EKG at the screening visit. And the BMI has to be between 20 and 30. And then the exclusion criteria, we are excluding patients with a pacemaker, with normal vital signs or clinically significant vital signs, patients who suffer falls in the last 6 months, and patients with history of syncopal episodes, or patients who are pregnant or planning to be pregnant. So this exercise program, we have this wonderful physical therapist in our unit, Zoe Shaitman. She designed this exercise program. And she called it, she was like 2 weeks thinking on the name, and she called it Proximal Resistance In-House Movement Exercise, PRIME. And it's a it's an exercise program that doesn't require any complex equipment. We provide the patient with a mat and elastic bands of different systems. And actually, there are some patients that don't use even the elastic band. They do the exercise without distance. And then after each exercise, she asks the patient how they feel, basically. And we don't want the patient to feel like the exercise is very easy, and we don't want the patient to feel like the exercise is very hard. So she is hoping that after each exercise, the patient grade the exercise according to this Omni resistance scale between 3 and 6. So the sessions, 2 sessions a week on non-consecutive days. And we also ask the patient, as I mentioned before, to make notes in the exercise diary of the number of sets and repetitions that they are doing, especially if they are doing the exercise on their own. And this is basically the exercise that the program includes. So you can see there like the forward and backward lunges, walking, sit to stand, lateral lunges, wall squat, lateral walkouts, deadlift, hip extension, mostly focus on lower extremity and core muscles. Then Pallof press, Pallof walkouts, plank with obviously modifications, marches and reverse marches. And before this exercise, all the patients do a warm-up of almost 5 minutes and a cool-down of almost 6 minutes. The entire session is between 30 minutes, 45 minutes, depending on the patient. And this is what we have. We started this study this year. I have to say that the winter in Boston is not ideal for the patients to come to the clinic, and nobody wants to be in Group A, but we are catching up now, and we have 5 patients already enrolled and randomized to Group B, 1 to A, and 2 to C. And the first patient already did 16 sessions, and the last 2 did only 4, but they are compliant. Obviously, they are motivated, and that's why they come to the clinic for this study. And we have 5 more that are scheduled in the following weeks. So we are targeting 24. So we have for now potentially 10 in total. And we will be happy if not to recruit more patients, and I will give some contact information, my last slide. So these are a little bit the demographics of the patient that we have so far. You can see there all ages. We have 4 females, only 1 male. We hope we can recruit more males. They have weakness. They don't fall. They don't use any assistive device to walk, but they have weakness. You can see there the grade of the hip flexor. They are weak. And then we measure the fatigue, daytime sleepiness, and also you can see there the time up to go. And they have expectations. Obviously, this is research. We don't know if it is going to be beneficial, but we also do a survey at the screening to see the expectation. They all agree that the exercise is going to improve their ability to perform daily activities and also the overall functioning of the body, also help with stress, with the psychological states, and the cardiovascular system. And they also think that this will give them a sense of personal accomplishment. So I want to thank you, patients and families, and also very much our physical therapist, Zoe Shademan, who is the one who basically designed with me the study, but the whole exercise program is because of her. This is her email, and also Blanca Escauriaza is the research nurse. So please, if you have any patient or any patient who may be interested, you can share this information with them, and they can email, and or Blanca will give them a call. And this study is funded by Myotonic Dystrophy Foundation. So thank you very much for that.
We have maybe time for 1 or 2 questions.
Hi, a really great talk. I was wondering for the self-directed patients, how you prompt them for how to do each exercise. Do you provide a handbook, or did you show them at the screening session of how to do each exercise to make sure they're doing each of them correctly?
So how we teach the exercises? Okay. So at the screening visit, we teach not me, Zoe teaches all the exercises, and she has spent a lot of time with the patient, especially those that go to group C. Zoe teaches the exercises at the screening visit. We gave basically the pictures of the exercises that I show. We give that on papers to the patient. And we also, the IRB, we didn't do it yet, to be honest. But anyway, the IRB included also to do the possibility to do a video of Zoe doing the exercises. So far, the patients that came, they got it very quickly. We don't have too much problem explaining the exercises. But for those patients who may have problems, we can also, per IRB, we can do a video of the exercises. And we can share that with the patients. And we check with telephone encounters from time to time and just ask about questions. Do you have any question about the exercises and all this? And yeah, this is the way we teach. Yeah.
Thank you.